The session will be delivered by Dr. V. Ramasubramanian, infectious disease expert, Apollo Hospitals, Chennai. Over to you, sir.
Sir, a small request before you start. There always has to be a bad person in the chair panel to say the time when it's over and when it's not. And we learn the lessons pretty late, so I request you to keep to the time. Thank you.
Thank you very much, and I'd like to thank Dr. Republica for the invitation, and Dr. Preetika Chari. That was a very enlightening talk. I think she's left. Anyway, it was I found it very, very insightful. Thank you so much. But my talk is more about good living than good death, because I think till we die, we have to make sure that we are treated well and we treat others well. So my topic is on the rise of hospital pathogens in the age of resistance. I will just give you a brief case. A 77-year-old male, hypertensive, diabetic with heart disease, hypothyroidism, Parkinson's disease. He's had a stroke in the past. He's also having chronic kidney disease with urinary retention on a Foley's for the previous 1 year. And he presents with fever and cough. All his family members have a similar illness. And when he's evaluated, his urine shows plenty of pus cells and the urine culture grows Klebsiella, more than 10 to the power of 5 colonies. And it is a highly resistant strain. You find that this is his culture report. Now, this is not uncommon. We do see this these days. So my question is, what antibiotic will you use for this patient? Any ideas? You find that this is sensitive only to colistin, tigecycline, chloramphenicol, colistin, and phosphomycin. All are parenteral antibiotics which need to be given 3 or 4 times a day and pretty expensive, anywhere from 10,000 to 20,000 a day. What would you use? Yeah, that's a very sensible answer. The first thing I wanted to convey to you is the presence of a report from a microbiology lab showing high levels of resistance doesn't mean that it's a commandment you need to follow up with. I specifically said this gentleman had cough and cold, and several members of his family had cough and cold. So this probably is only a flu-like illness, and this is a red herring. Anybody with the indwelling Foley's catheter will show a high level of resistance in their urinary pathogens. About 99% of people will harbor a significant bacteriuria more than 4 weeks after their Foley's catheterization. So the question is, please interpret a report with caution. Okay? So in my talk over the next 15 minutes or so, I shall probably come up with what you're going to do as part of antimicrobial stewardship, which means using antibiotics wisely. George Orwell said that all animals are equal, but some are more equal than others. And that's the same, it's true for resistant bugs. Because how does resistance happen? You have a pool of bacteria. Most of them are sensitive bugs. There is one resistant bug sitting in that. You use antibiotics. The antibiotics select out these resistance. So it kills all the susceptible bacteria, and then slowly the resistant bacteria get selected out and increase in number. And this is subsequently spread to other organisms. This mutation, this plasmid can be spread to other organisms. So the principles of resistance is very important to understand. Please remember that given sufficient time and drug use, resistance is inevitable. Resistance is progressive, evolving from low levels to high levels. Organisms resistant to one drug are very likely to develop resistance to others. Once resistance appears, it declines slowly, if at all. And the most important point is the use of antibiotics in one person impacts the entire community. I can use antipsychotics, I can use anti-diabetics, I can use antihypertensives, no issues. But when I use an antibiotic, it alters the person's microbiome. It selects out resistant bacteria which are sent out through the fecal material. This can contaminate water sources, and this can spread to the entire community. And if I'm in a hospital and I'm colonized by a resistant bug, the bugs which are shed from my skin can contaminate the environment and can spread to others. So this is very important to realize that how you use antibiotics is very important. And as Friedrich Nietzsche said, that which does not kill us makes us stronger, which means if you are not treating your antibiotics, your bacteria appropriately, there is a very high chance that they will select out and start causing problems. I will skip all this now. So the importance of antimicrobial resistance nowadays, we find it's a global emergency. We find that it is one of the most challenging health problems, and it is believed that by the year 2050, almost 10 million people will be dying because of direct consequences of antimicrobial resistance. Probably the number one cause of death is going to be AMR. And South and Southeast Asia is going to contribute to 5 million deaths. So this is very, very scary statistics. This is now the truth, and as I said, we are seeing many patients with highly resistant bacteria which are difficult to treat. If you look at healthcare associated infections also, whether it is bloodstream infection, central line associated bloodstream infection, UTIs, there is a high level of resistance in these pathogens also. So it is becoming very difficult to treat these bugs. If you look at the trends in India, the rates of ESBL, what is referred to as extended spectrum beta lactamase, which means organisms which are resistant to third generation cephalosporins, is upwards of 70%. Even carbapenem resistant bacteria, in which case your imipenem, meropenem, ertapenem don't work, is climbing up from 15% to now going up towards 40%. So this is very, very worrying. Why? Because the mortality associated with these infections caused by these organisms is high, the outcomes are poorer. It is believed that mortality due to MRSA, which is a resistant gram-positive organism, is very high when compared to susceptible organisms. And more so, the cost of treating these bacteria also is very high. So which means this is something which we have to tackle if you are going to have patients having better outcomes. Otherwise, you don't need to wait for good death. They will come to you with bad infections much early in life. This study was done in India, showed that the cost of treating patients with resistant bugs was much, much higher than those with sensitive bugs. So it is time to wake up. We have run every test we could think of, and the results show that you are out of money. This is what is happening in corporate hospitals now. We have patients, after 5 days you diagnose and start treatment, and they say, sorry, we have run out of money, we have to go. So this is the reality. So what do we do about this? What can, as I said, even though this is not part of maybe palliative care in the real sense, but leading up to it, this is something which you need to be very, careful about. So antimicrobial stewardship basically refers to the appropriate use of antibiotics. Whether it is the choice, whether it is a dose, whether it is the administration, whether it is a duration, how we use antibiotics is what is referred to as antimicrobial stewardship. And I'm going to say 5 steps in whichever hospital you're working, whether it is palliative care, intensive care, community hospital, you need to understand these 5 things. 1, you need to compile your antibiotic policy to treat patients in your hospital. Please do not base your choice of antibiotics on Western guidelines. You compile the data in your hospital. What is the susceptibility profile of the bugs seen in your hospital? What are the infections seen? So for example, let us put as a community acquired infection, typhoid cases. In my hospital, I have had about 30 cases of typhoid in the last 1 year. The bacteria is Salmonella typhi, which says that 98% are resistant to ciprofloxacin, 5% are resistant to cotrimoxazole, 3% resistant to azithromycin, and 2% resistant to ceftriaxone. So which means if I have a case coming to my hospital of suspected enteric fever, the choice of drug would be either ceftriaxone or azithromycin. I can also use cotrimoxazole, but never ciprofloxacin, which used to be the drug of choice 15 years ago. So you define the condition, you say which is the bacteria causing this condition. If somebody comes to you with, say, a urinary tract infection, in my hospital, 100 cases seen in the last 1 year, majority grew E. coli and Klebsiella. The susceptible antibiotics are this. So if I have a patient coming with a suspected UTI, I will send the urine culture and start the patient on, say, cefoperazone sulbactam or cotrimoxazole as the drug of empiric therapy till I get the culture. So define this for your hospital. I repeat, your antibiotic policy should be regionally relevant. Phase 2, the importance of diagnostic stewardship. Ensure a culture of cultures where if you're going to start somebody on broad spectrum antibiotics, make sure that cultures are sent off. This is my colleague, this is how he reacts. What do you mean? You only send the biopsy to histopathology and not to microbiology. So microbiology is very important in determining choice of whatever infection is underlying. So you need to have your microbiology labs standardized. You need to ensure which drug to report for which bug. We find in India a whole list of 25 antibiotics for a drug which probably you need to report only 3 or 4. Because this confuses the clinician and this increases wrong choice of antibiotics. Ensure that limited antibiotics are mentioned and cascade them. If it is sensitive to ceftriaxone, you don't need to report that it is sensitive to meropenem, because clinician would prefer to use meropenem, and that is not correct. The broader the antibiotic, the more collateral damage you cause. So, and also the lab should reject samples which are not properly collected. If I am sending a Foley's catheter tip for culture, that should be sent back from the lab. So empower your lab to take the appropriate specimens and report tests accordingly to help the clinician. Step 3, if you're choosing the antibiotic, you have your antibiotic policy, okay? But you need to have a syndromic diagnosis. Every ID problem has 2 questions to answer. What is the syndrome? When somebody comes to you with fever, we saw the first case, he came to you with fever, cough and cold. So that was a respiratory or maybe a pneumonia syndrome, not a urinary tract syndrome. So I would ignore the urine culture. If a patient comes to me saying, I have dysuria, I have frequency, I have blood in my urine, that becomes a urinary tract syndrome. If he comes with fever, headache and vomiting, I think of a meningoencephalitis syndrome. So define clinically what the syndrome is. Based on the syndrome, what are the likely organisms which could be causing the problem? So if I'm treating a pneumonia, I would think of strep pneumoniae, H. influenzae, moraxella, chlamydia, legionella, mycoplasma. I won't think of, Acinetobacter baumannii coming from the community. So define the syndrome, find what the organisms are, you know the local susceptibilities in your region, and then choose the antibiotic. This is the algorithm which we use. If it happens to be a hospitalized patient with a hospital-acquired infection, again, you need to define the syndrome, make sure that you distinguish colonization from infection. A Foley's patient catheterized with Foley will show bacteriuria. A patient with an endotracheal tube on a ventilator will show bacteria. Do not treat the endotracheal tube, treat the pneumonia. If the X-ray is clear, do not use antibiotics for bacteria which are picked up in the endotracheal tube. Treat the UTI, not the Foley's catheter. So very important to make sure what is the syndrome, what is the likely bug, and based on the susceptibility, till you get culture results, give empiric therapy and make sure you send the cultures accordingly. Avoid prophylactic antibiotics. We have a culture where we dish out antibiotics, as though they are the answer for all problems. So avoid prophylaxis unless it is used for surgical cases 1 hour before the surgery. Otherwise, more than 24 hours of antibiotics in a surgical patient for an elective clean surgery is unwarranted. Shorter courses are better. We no longer give more than 5 to 7 days for most conditions. The 10 days, 2 weeks, 3 weeks, no longer. The shorter it is in a person who responds, that's the best course. Step 4, adopt infection control. If you have a patient in your hospital who's colonized or infected with a resistant pathogen, please isolate them geographically, because healthcare workers go from one patient to another, carry bugs from one person to another. So remember infection control. And lastly, ensure that you audit the process in your hospital. If you have all these steps put in place in your hospital, your antimicrobial resistance can at least be controlled and you will have better outcomes for your patients. So I'm going to leave you with the last slide. Practical approach, limit surgical prophylaxis to 24 hours. Avoid routine use of prophylactic antibiotics. When somebody comes to you with an influenza-like illness, cough, cold, and fever, and you suspect the possibility of flu or any other respiratory virus, do not use antibiotics. The culture has become so strong that even patients who come to you say, I've been having cough, cold, and fever. I've already taken azithromycin for 3 days. Give me something. You need to tell them, a respiratory virus, if you take antibiotics, will clear in 5 to 7 days. Whereas if you don't take antibiotics, it will take 1 week to clear. So that's what you need to convey, that antibiotics are not indicated. Send cultures before starting parenteral antibiotics. If you're using oral antibiotics, no routine cultures. But if you're using IV antibiotics, send cultures. Encourage accurate diagnosis than giving empiric antibiotics, especially injectables. Avoid empiric antibiotics for fever in a hemodynamically stable patient. Select empiric therapy based on your guidelines. Get the dose right. Avoid combinations. De-escalate. Once you find an antibiotic which will work, which is more narrow spectrum, use that. And lastly, limit the duration of therapy. So please remember, you have to customize your approach. That's the Indian Mona Lisa. So customize your approach in the use of antibiotics and make it relevant for your patients. Thank you.
Thank you, sir, for that crash course in antibiotic stewardship. It was absolutely scintillating with the right mix of humor, if I might say. We thoroughly enjoyed it. I have one question and a comment. I'll go with the question first because you have said a lot about antibiotics, which probably an MBBS undergraduate or even MD General Medicine postgraduate would probably miss in their entire training. So this aspect, like we talk about empowering healthcare professionals about palliative care, are there any courses which will empower normal doctors about usage of antibiotics appropriately? Because you practically have the patient at gunpoint saying that, look, you give me this injection, and you know, people just fall into that trap and start prescribing even if they don't want to.
Yes, unfortunately, our medical curriculum doesn't prepare us for this kind of management. You know, I get daily calls. I had a call 2 days back from a patient in Delhi. A doctor actually called. And he said, one of the patients we are treating is being managed in the ICU, but I'm not happy with the way they are treating. I wanted your advice. And he called me. And when I spoke to the doctor, he said, this is a patient with renal transplant, with a respiratory infection. And he's having a low-grade fever. We have already used meropenem for 1 week. It didn't work. We added vancomycin, and we also gave cefepime. What is the latest? Ceftazidime, avibactam. It's not working. We have added caspofungin. It is not working. What antibiotic can we add next? That is a question. So the first question I ask is, what are you trying to treat? I know your patient has fever, but what is your differential diagnosis? They didn't have an answer. So I said, stop everything, assess the patient before we treat. And this is a stable patient in the ICU. So, right now we are doing a lot of CME, the Clinical Infectious Diseases Society, for which I was a president 2 years back. We are coming up with a lot of lectures, online programs, almost weekly, once or twice we have programs in educating people, whether it is GP or whether it is specialists, we are in the process of doing it. I can't, advise any specific booklet or any specific course which will help, but we are in the process of doing it, so I will keep what you said in mind. All the doctors need this kind of practical approach. And as I said, I'm a strong believer in making it relevant to your place of, practice. I'll tell you what happened. My exposure to palliative care was in the early 90s. I was in the UK, I was in London when I was managing HIV patients. And a lot of these HIV patients, because this was before the antiretrovirals, used to be sent to hospices to die because there was no treatment available. And the patients from Africa, we had several of them from Kenya and Nigeria, who they used to tell me, the boss wants to send me to this hospice, but I don't want to go because in England they say, go to hospice to die with dignity, and they will kill everybody there. So I don't want to go to a hospice to die, you manage me in the hospital itself. So the cultural aspects of terminal care also needs to be kept in mind. This dying with dignity is a very, very Western term. People don't understand that here, and they think they just put you in a hospital and shove some morphine and let you die. So anything, and even ID and use of antibiotics, should be culturally and geographically relevant.
Thank you so much. Just a last comment. You mentioned that probably antibiotic stewardship was not relevant to palliative care. In fact, 100% it is relevant. In palliative care, in fact, we pride ourselves because we actually treat infections, only the ones which matter at that point of time in the patient's trajectory. And two, we always take, prescribe medications which are relevant to the setting. So I think we are very much aligned.
Thank you, I stand corrected. Thank you very much.